Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is care management and remote patient monitoring. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the question pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We will respond to the questions posed after the webinar by email. We have posted in the handout pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenter, Martie Ross.
Thanks, Laura. Welcome, everyone. We are in sort of this in-between season. We've had the federal fiscal year rules published in final form, but we're still waiting on the calendar year final rules to publish. So we're waiting on the Medicare physician fee schedule, hospital outpatient rule, and the like. So in this interim time, we looked through the questions and comments we've received over the last year on specific topics that you all may be interested in for a deeper dive on the regulatory scheme around them. And at the top of the list was providing care management services and remote patient monitoring. So we'll spend the next hour walking through how CMS has developed the billing rules around these services. Back in 2013, now a decade ago, when CMS first introduced reimbursement for transitional care management, it was really a significant development, but really the first time that CMS was offering reimbursement for services that were not provided within the four walls of the clinic or the four walls of the hospital. And over the last decade, CMS has really grown this range of virtual services, and in an attempt to reach out beyond the hospital and the physician clinic and meet patients where they are and help them better manage their conditions with the intention of reducing emergency room visits or inpatient admissions and really improving the overall health of the population. So we'll start with care management and walk through the types of services that are now reimbursable under the Medicare physician fee schedule, and then we'll address remote monitoring. So let's start with care management. And what had started as one code back in 2015, CPT 99490, has now grown into a family of codes for care management services. So let's just review them briefly here so you can understand the distinctions between the different types of services. 99490 is the basic chronic care management services furnished by clinical staff under the general supervision of a physician. It is measured in 20-minute increments. The initial 20 minutes billed under CPT 99490. Each additional 20 minutes billed under 99439. You can bill up to 2 units of 39, meaning 60 minutes of chronic care management services are reimbursable each month. The medical necessity for these services is defined by the condition of the patient. They must have at least 2 chronic conditions that are expected to last at least 12 months or until death of the patient, and that these conditions must be such that they place the patient at risk of death, acute exacerbation of decomposition, or functional decline. Core to these services is a comprehensive care plan that has been established, is implemented, and then monitored and revised for the patient. Now, with that very broad first step into care management, CMS continued to refine how it would reimburse for these services. So the first step was the creation of a reimbursable code for when chronic care management services are being delivered directly by a physician or a non-physician practitioner as opposed to clinical staff. And so effectively the same requirements as the 99490 chronic care management services, but instead in this case, rather than clinical staff under general supervision, it's in fact the physician or the non-physician practitioner who's providing, in this case, at least 30 minutes of services. First code measured by 20 minutes. When it's physician performed, it's measured in 30-minute increments. Again, there's a code for the first 30 minutes, a separate code for subsequent 30 minutes. The subsequent code can be billed for 2 units in a month, meaning you can do an hour and a half of services under this code. As you expect, when we look at the reimbursement rates, they are higher for this service, both because of who is performing the service, as well as the additional time that is involved. Next up is complex chronic care management, billed under CPT 99487. This goes back to the model of being provided by clinical staff under general supervision of a physician or non-physician practitioner. This is measured in an initial 60-minute increment and then with subsequent 30-minute increments under that. Here, the requirements are the same as 99490, except we have to add that the patient's condition must require moderate to high complexity medical decision making. So this code was intended for the more complicated cases that we anticipated would take significantly greater amount of time. As you see under this code, you can bill 2.5 hours of services. And again, the reimbursement is adjusted accordingly. Interestingly, there is no CPT code and thus no separate Medicare reimbursement for complex CCM furnished by a physician or non-physician practitioner. There's only the code available for when clinical staff provides this service. Also appreciate that complex CCM was made reimbursable prior to there being add-on codes for 99490. And thus, at the end of the day, when you do the math, the reimbursement for traditional CCM, 99490 plus the 2 allowable units of 99439, that reimbursement is actually greater than the reimbursement for complex chronic care management. So as you'll see, the utilization on this code has been low. It was primarily a gap filler for a period of time before we got those add-on CCM codes. And thus, we generally don't see providers utilizing this particular code at this time. Appreciating that there were instances when there was an episodic need for care management services, CMS created reimbursement for principal care management. Again, very similar to chronic care management in that it's care provided by clinical staff under general supervision. This is also measured in a 30-minute increment, but instead we're going to focus on a single chronic condition, one that's expected to last 3 months, and again, place the patient at risk of death, acute exacerbation, or functional decline. It is a condition that requires the development of a disease-specific care plan, and it requires ongoing communication and coordination with other practitioners. So think of this as the patient recently diagnosed with heart failure, and they're having to make significant lifestyle changes. They're at high risk of readmission to the hospital given a prior acute episode, that you just need the intensity of services for a period of time. That is what principal care management was attempting to fill that gap. And again, the initial 30 minutes billed under the 2.6 code, and then additional 30-minute time periods billed under 99427. In this instance, you're allowed to bill up to 3 units. So you can end up with 2 hours of total services reimbursed under principal care management furnished by clinical staff. Of course, the sister code here is PCM, but furnished by a physician or non-physician practitioner. Same requirements as principal care management furnished by clinical staff, but with the change that now this is being furnished directly by the physician or the non-physician practitioner. And just to clarify, when we talk about the services furnished by clinical staff under general supervision, that does not mean that if you perform principal care management by clinical staff under direct supervision, you can bill it under a physician or non-physician practitioner. CMS is clear that in fact this has to be personally performed by the physician or non-physician practitioner to qualify for reimbursement under these codes. Again, first 30-minute increment under the 99424, the second, and up to 3 units reimbursed under 99425. Finally, we have a HCPCS code, G0511, which is used for reimbursement to rural health clinics and federally qualified health centers as general care management services. As you know, RHCs and FQHCs bill on an encounter rate. So for whatever service is provided at that encounter, there's a flat rate reimbursement for those services. And that encounter rate is limited to services that are defined as either RHC services or FQHC services. But to ensure that we could extend out care management services to the patients of these providers, CMS created this general care management code to provide reimbursement to these providers. So under this code, it is 20 minutes or more of clinical staff time, again, under the general supervision of a physician or non-physician practitioner. But it can be chronic care management, it can be behavioral health integration, and again, for the calendar month. Appreciate that there's no add-on code here, that it's only for at least 20 minutes of services in a given month. So even if the RHC staff ended up doing an hour and a half of care management services for an individual, they would still only be reimbursed once under this code for the total time. So that's our family of CCM codes. Let's talk about where utilization is for these services today. Because I think the chronic care management codes have been one area where CMS has been looking to promote utilization and to increase utilization, recognizing the value these services have in reducing long-term costs and improving health outcomes. What we have available to us today on the Medicare website is 2021 utilization data. The 2022 utilization data should be released here in the next few weeks. But what we know today is how many of these services were provided in 2021 to original Medicare, traditional Medicare beneficiaries. And if we just focus in on 99490, that being the lead code, we have the number of beneficiaries served that received that service is under 1 million, right? 886,000 beneficiaries who received the service. Of course, fewer beneficiaries than total services, because this is typically a monthly service. So you'd expect there to be far more units of service than beneficiaries. This would mean that on average, each beneficiary is receiving about 4.5 months of this particular code. If you consider that we have about 36 million original Medicare beneficiaries in 2021, and the rule of thumb you hear frequently is that about 2/3 of Medicare beneficiaries have 2 or more chronic conditions. That means that less than 5% of potentially eligible beneficiaries are now were receiving CCM services in 2021. Then if you look at the number of practitioners who are furnishing these services, it is also small as compared to the total population. There are about 1 million physicians enrolled in Medicare. Of those, about 360,000 are traditional primary care providers, family practice or internal medicine. And what you see from these numbers, only about 10% of primary care physicians are furnishing CCM services today, or not today, in 2021, I apologize for that. So there's still a long way to go in adoption and implementation of these services. Part of the reason is the reimbursement rates. Part of the reason is the complication of the billing rules that CMS have applied. So let's spend some time on those two issues, walk through where the opportunity are for care management services. I apologize for the smaller print, but this is a summary of 2023 reimbursement for the codes that we just discussed. And as you see, there's generally a difference between the non-facility rates, so provided in a physician practice, or the facility rate provided in the hospital outpatient department, which is lower. But three of these codes, importantly, have APCs tied to them, meaning that if, for example, when you provide CCM in a hospital outpatient department, so you have a physician office that is operated as a hospital outpatient department, in addition to billing on the Medicare physician fee schedule to reimburse the professional services rendered, you also have the opportunity to bill on the outpatient prospective payment system for the underlying costs associated with delivering that service. And CMS has crosswalked 99490 to APC 5822. And you see there the reimbursement for that code for 2023 sets it about $76. So there's the opportunity for that additional added reimbursement if the services are originating from a hospital outpatient department. We'll talk about how you define place of service as we walk through the billing codes. There are also APCs attached to complex CCM, as well as principal care management. And you, again, have that opportunity for that additional reimbursement if furnished in a hospital outpatient department setting. Of note, G0511, which is the General Care Management Code for rural health clinics and federally qualified health centers, you'll see that's the highest of the reimbursement, of course, except complex CCM, but it's higher reimbursement because it is a blended rate of the care management codes. CMS is proposing this year to change the manner in which that amount is calculated, but is a higher rate, appreciating that there's no add-on code for it. So while, yes, 20 minutes of care management is going to be reimbursed the same way as 75 minutes of care management, but the higher reimbursement for the lower end is intended to match the lower reimbursement at the higher end of minutes. We do not have the, at this point, I did not include the 2024 rates. There are some slight adjustments to the RVUs for the care management codes, very slight, proposed in the 2024 physician fee schedule. What we're waiting on, of course, and the big story to be told, is what the conversion factor will be for 2024. As you recall, CMS has proposed a pretty significant cut, about 4%, to the conversion factor for 2024 as a result of the mandatory reduction following the 2023 congressional step in to raise the fee schedule, but also then the addition of the add-on code for complexity and the impact that has on budget neutrality, also forcing the change in the conversion factor. So once that final rule is published, we'll actually know what our conversion factor will be for 2024 and how that will impact the reimbursement for these care management services. There are other care management services that CMS has developed in the last decade. Again, I've referenced previously the original transitional care management codes. A few years back, we added behavioral health integration, 2 codes here, the psychiatric collaborative care model and the general behavioral health integration. These are codes intended to bring behavioral health services into the primary care setting. The psychiatric collaborative care model with the involvement of a psychiatrist as a consulting physician. The general behavioral health integration intended to utilize individuals who've been trained in behavioral health, but not necessarily licensed at a level that they can bill on their own for those services under their own provider number. This allows for the integration of those services into primary care to be billed under the primary care physician's provider number. Last year, we added chronic pain management. We still have the HCPCS codes available for that. more prescriptive than care management, but intended to focus specifically on patients that have pain management issues and interventions appropriate for those individuals to avoid pharmacological management of those conditions. And then in the 2024 physician fee schedule proposed rule, CMS is offering up 2 new care management services, the first being community health integration, which is reimbursement for activities by community health workers, so helping beneficiaries sync up with local resources to address social determinants of health, helping them navigate systems, helping them secure necessary services and the like. And then principal illness navigation, kind of a variation on principal care management. This is intended again for a significant episode of care. The example used in the proposed rule is an individual recently diagnosed with cancer, helping them navigate both interactions with providers as well as social service needs for that period of time. We'll see where CMS goes with this again when the final rule is published. But again, just more of these opportunities for providers to take a leadership role in reaching out to patients, again, meeting them where they are, providing those additional services they need, so the traditional medical services offered in the clinic or in the hospital are better managed. You can avoid higher cost episodes of care. Oh, sorry about that. Cooperated. Here we go. Oops, so let's talk billing rules around our care management codes. We'll group these into 8 different topics. Right there, you can see the complexity that providers encounter when they want to provide these services, starting to understand all of the requirements for reimbursement. From the beginning, CMS has required that one obtain consent from a beneficiary as a condition of providing these services. In the case of the care management services, CMS wants this to be a conversation, that certain information is explained to the patient that is unique to these care management services, because they are different than the traditional office visit services. So to secure consent, you must inform the patient of the nature of the services and how they are accessed, the fact that only one provider can furnish care management services at a time, that the beneficiary has the right to stop the services at any time by revoking their consent, which would be effective at the end of the calendar month, and importantly, that the beneficiary is responsible for the payment of a co-payment or deductible associated with these services. Again, CMS's concern is that beneficiary doesn't expect there to be a copay because it doesn't look like other services that they've received. So once you've explained this to the beneficiary and they give their consent, either in writing or it can be a verbal consent that the provider then documents in the patient's medical record. If a beneficiary revokes their consent, and that includes signing up with a new provider to receive care management services, a provider no longer can bill for care management services after the then current calendar month. Consent, we've learned when there are audits of CCM billing records, it is certainly a focal point that you have that information included in the medical record of documenting the informed consent, that the certain requirements of consent were explained to the patient and that they in fact did consent to receive the services. Next up is the established patient role, as it's referred to in the shorthand. What this is actually an initiating visit requirement. So CMS clarified back in 2017 the initiating visit rule, saying that before you initiate care management services for a beneficiary, you need to have an initiating visit at which CCM is discussed. And that visit must be at least it must be a comprehensive E&M visit, so a level 2, level 5. It can also be the face-to-face visit involved with transitional care management. It could be an annual wellness visit or an initial preventative physical exam. The exception to the initiating visit requirement is for patients who have been seen within the last year. And CMS's logic was that if this is in fact an established patient, someone you provided care for in the last year, then it's not necessary to have the initiating visit because you already have information about the patient, you've interacted with the patient, you've built a medical record from which you can begin developing a care plan. And thus, to require an initiating visit in those circumstances would be a redundant, medically unnecessary visit. And so that is not necessary if the patient's been seen in the last year. The initiating visit, if you are required to perform the initiating visit because it's effectively a new patient to you, it is still separately reimbursable. So it's not part of the CCM reimbursement, it's the initiating visit separately reimbursable. And noting that if additional time is spent in that initiating visit beyond the normal amount of time expected because of work on assessing the patient or beginning the development of a care plan for that patient, CMS did create a separate add-on code, GO506. The add-on code must accompany, is billed with the initiating visit, so it's listed on the same date of service, although CMS notes that the actual work can be done after the initiating visit, just critical to do it. It has to be billed as an add-on code to the initiating visit. CMS has clarified that an initiating visit may be performed via telehealth, but only if that telehealth is a reimbursable service. So if you think back before the pandemic, when we had the restrictions on telehealth reimbursement, the geographic restriction have to be in a rural area, the location restriction, they have to be physically present at a facility. It was very narrow band of services that were reimbursable by telehealth. Now, during the PHE and now through this post-PHE period where there's much broader coverage for telehealth, it's more practical to be able to utilize telehealth for the initiating visit for CCM services. This does bring us to one of the thorny issues we encounter with the care management services is established patient to whom. This concept of the billing practitioner versus the referring practitioner. Because the rule, CCM follows the rule that's applicable to all Incident to services, that the service is billed under the MPI of the supervising physician. So the billing practitioner is always the person who is supervising the clinical staff who's performing the service. If you, as a practical matter then, if the referring practitioner is the individual who's had the ongoing interaction with the patient, and they determine it would be great for this person to receive CCM services from clinical staff, and there is this interest in referring that patient for care management services, or a different physician would be supervising the care management program, overseeing the clinical staff. How do we reconcile that with the established patient rule? In particular, it becomes of concern if for providers who utilize third-party case management companies. These are companies that hire the clinical staff, train them to provide CCM services, and then partner with practices to refer patients for those services. And CMS has indicated that's appropriate so long as that treating physician remains involved in the patient's care. So there's a lot of navigation around this established patient rule, particularly when we have ideas of shared or centralized care management services. I mean, having worked with a number of folks who stood up this program, appreciation that there are significant barriers to entry in terms of cost of standing up a CCM program, especially if you're serving a relatively small patient population. There are certainly economies of scale and efficiency to be gained by developing centralized programs. But what we're learning is it's this navigation of the established patient and initiating visit requirement that is challenging. Certainly waiting for CMS to provide additional guidance on this to clarify how these arrangements will work appropriately to ensure the proper level of clinical integration between the referring physician and the billing practitioner. So yes, the information coming out of the care management activities is feeding into the treating physician's ongoing care. The information in the patient's medical record is available then to the care management team as they work with the patient. If that's a seamless relationship, then how exactly do we navigate that and make sure we have compliance with the established patient rule? Oh, it jumps too fast on me sometimes. I apologize. CCM, as CMS has noted that a practice that provides CCM, an entity that provides CCM, has to have certain capabilities to be able to support the patient beyond just that 20 minutes of clinical staff time spent with the patient. CMS expects that a practice that furnishes CCM utilizes a certified EHR for specified purposes. They have to ensure the beneficiary has access to care, in particular, a means for the patient to gain access to a provider in the practice on a 24/7 basis to answer acute and urgent care needs, and also the ability to obtain successive routine appointments. Requirements with regard to transitions of care. The practice has to be able to follow up with patients after an ER visit and also provide some form of transitional care management, even if it doesn't meet the specificity of billing for TCM, but also then the capacity to coordinate referrals and share information electronically with other clinicians. And finally, the ability to provide for coordination of care, that there is links between the practice and home and community-based services that can help meet patients' social needs, and of course, being able to document those communications in the record. It's interesting, with these rules, again, these billing rules published back in 2015, these were more cutting edge, more unusual to see these types of capacities within clinics. These seem much more every day as we've developed capacities in our practices. But here you get the idea what CMS is looking for, again, is this integration of the care management activities into the ongoing care of the patient. Fourth up, let's talk about general supervision of clinical staff. And I've made reference to that term several times. First, start with who's clinical staff for purposes of these services. And CMS refers us to the CPT codebook definition of clinical staff here, which is an individual who works under the supervision of a physician and has been allowed by law or regulation or facility policy to furnish certain services, but they themselves do not report for those professional services. So registered nurses, licensed practical nurses, medical assistants, LPNs, the fact that whomever those individuals with appropriate training, education, experience, that supervising physician determines in their judgment is capable of providing these services. Think of it as, the delegation of authority by a physician. They remain ultimately responsible for the care provided, but they can make the decision to delegate certain responsibilities to other individuals. So similar here in the concept of general supervision by clinical staff. So what is the responsibilities of the billing practitioner under general supervision? Of course, is to provide oversight and direction for the care management team. Again, importantly, ensuring that staff has the experience and expertise to perform the specified care management activities, so they have a very defined scope of work for the clinical staff. They are available to address staff questions and concerns. Notice it's available, not immediately available. Because they're not required to be physically or virtually present when staff are providing these services, nor are they required to review and sign off on all documentation. The general supervision level, certainly a step up from the traditional incident to direct supervision, but this is more management of the program, oversight of the personnel by that billing practitioner. Fifth requirement for care management services is the care plan, which is the central document that defines the work to be done by the care managers with the patient. You are required as part of CCM to develop and regularly update an electronic care plan. It just needs to be in electronic format. Just can't be on a piece of paper. This is effectively what the rule is here. That care plan should be based on the physical, mental, cognitive, psychosocial, functional, and environmental assessment of the beneficiary's needs. It's the true 360 of what this beneficiary requires. Taking an inventory of resources and supports available to that patient. So what are the other doctors they see? Who's their primary caregiver? That type of information being captured in the care plan. It should address all health issues, not just the qualifying chronic conditions. The exception there, of course, is with principal care management. In that case, the care plan should be focusing on that specific condition for which the individual is receiving principal care management services. The care plan should also be congruent with the beneficiary's choices and values. Again, though requested on several occasions, CMS has not provided a model care plan. There are several models available that have been developed up that capture different information about patients in different formats. There really isn't a one size fits all because you are really intending to identify what are the challenges for this patient and then what are the appropriate interventions to address those challenges for patients. Certainly those challenges change over time, the interventions change over time, so that document should be regularly updated to match the patient's current condition. CMS requires that other individuals beyond the provider have access to the care plan. In fact, you have to offer the patient either a paper or electronic copy of their own care plan. And they also, practice has to have the capability to share the care plan electronically with other providers involved in the patient's care. So this degree of transparency around the care plan. What I can't answer for you is, as the care plan is updated, do we have to keep sending new versions to the patient? And CMS has not directly addressed that question. But the idea here is that we want the patient informed of what's going on with care management services. If minor revisions, not necessarily, but significant changes would be appropriate, I believe, to share that with the patient to meet the access to care plan requirement. Number 6 is, what are care management services? CMS provides a non-exclusive list of the types of services that they believe would be included in ongoing care management. And makes a specific note of the importance of medication reconciliation, oversight of a beneficiary's self-management of their medications, appreciating that that often is the breaking point, that folks don't understand what they're supposed to be taking when, they don't appreciate the side effects or the contraindications, they take themselves off medications. It's just critically important that part of care management is bringing this back around to ensuring that the medications that have been prescribed are being taken in the manner recommended. Ensuring that the beneficiary receives all recommended preventative services, so flu shots and COVID shots, part of the process there, making sure those are arranged for. Just ongoing monitoring of the beneficiary's condition, both physical, mental, and social, and keeping tracks on that. And addressing those social determinants of health. And again, meeting up with those community services to help resolve any gaps in care. Documentation of care management services, certainly date and time, because this is a time code, you have to be able to document the amount of time. The gold standard, of course, for documentation of time is start and stop times. It's not mandated. You can record time as just total minutes, but At least auditors will tell you the preference is to inclusion of start and stop times of providing the services. You would want in the documentation the person furnishing the services with their credentials and a very brief description of the interaction with the beneficiary at the time of the care management services. How do we count minutes? There's actually some good CMS guidance that we've been able to glean over the years out of the Federal Register of Notices, as well as a few. CMS has published 2 frequently asked question documents that address some detailed CCM issues, as well as the ongoing MedLearn Matters article on CCM. What we know is that you can include face-to-face services, but that should be the exception, not the rule. The assumption being a face-to-face service is typically going to be a component of a different evaluation and management service. So if you're providing services face-to-face, you have to be able to demonstrate that it is distinct from what would otherwise be a part of an evaluation and management service, so to prevent that double dipping. There is no requirement in CCM that there be direct interaction with the patient. You can be performing services on the patient's behalf, such as coordinating services. You may include billing practitioner time if not part of a separately reimbursable service. So in addition to clinical staff time, if the billing practitioner spends time reviewing a case or interacting with the patient for some reason, you can include that as time toward billing on the clinical staff cases, on the clinical staff billing. But again, exception, not the rule. It should not be part of any other evaluation and management services. For counting 20 minutes, you can aggregate across multiple days. So 5 minutes here, 5 minutes there, but the total minutes cannot be rounded up. So if at the end of the month you have 19 minutes of care management services documented, you don't have a billable service, nor can you carry forward time from one month to another. So you can't add the 19 over into November to count your 20 minutes in November. Care management services may be furnished by different individuals, but you cannot count time for 2 staff members providing services at the same time. So if Nurse A and Nurse B are talking about a patient and trying to resolve an issue, only the time for one of those nurses can be counted for purposes of billing. And then if you are providing services for 2 patients at a time, so 1 care manager, 2 patients listening to the instructions, the time has to be allocated between the patients. So if I spend 10 minutes doing that, each of those 2 patients is going to get 5 minutes credited towards them. The double dipping rules. There's certain things you can't bill CCM with, and the list is getting smaller. That's the good news. CMS has ratcheted back the double dipping rules, but the core rule is only 1 practitioner can bill for CCM for the same patient during a given month. Now, and the same practitioner cannot provide CCM and PCM for the same patient during the same month. However, 1 practitioner can bill for CCM and another practitioner can bill for PCM for the same patient during the same period, even if those 2 practitioners are part of the same group practice. Because again, PCM is intended to be very targeted on managing a specific episode, where CCM is broader overall health and condition of the patient. There are certain exclusions. You cannot bill CCM and PCM for any of the services during the same 30-day period as home health care supervision, hospice care supervision, or ESRD services. And finally, you cannot count time towards CCM if the patient at the time the service is being rendered is a hospital inpatient, is in a SNF Part A stay, or they're receiving transitional care management services. So because they're receiving similar services furnished by a different provider, you cannot add on the time furnished for CCM. Finally, let's talk briefly about, no, not finally, let's talk about claim submission. Again, you bill under the MPI of the practitioner providing general supervision of the clinical staff. The place of service to be listed on the code is where a face-to-face visit would normally occur. This was an issue early on because CMS described CCM as being furnished incident 2 under general supervision. But we don't have incident 2 billing in the hospital outpatient department. So CMS has clarified, even though there is no institute billing in a hospital outpatient department, the practitioner is being reimbursed under the fee schedule for the time spent supervising hospital staff who are furnishing the care management services. Thus, that's how we have billing of care management services out of an HOPD. The date of service for CCM is any date within a calendar month after the minimum time threshold has been satisfied. However, if you're billing for multiple units, so if you're doing 1 unit of CCM and then 2 add-on units for the additional 20-minute increments that you performed, the add-on codes are just that. They have to be billed with the same date of service as the initial code. So if you're billing 99490 on October 11th, you're also going to have to bill the 2 units at 99439, also with the date of service of October 11th. And the other issue that comes up again and again, perennially, is CMS has been asked a number of times to waive the copay for care management services. They insist they do not have the authority to do so beyond the authority they had during the COVID-19 public health emergency. So we continue to have to charge beneficiaries the copay and deductible for these services. That's a lot of care management at one time. We maintain and update annually a white paper on providing and billing Medicare for chronic care management services, a more in-depth 20-page analysis of these rules, so that's available to you for more information. So with that, let's switch gears and talk about remote patient monitoring. Remote patient monitoring is the generic term, RPM. There are 2 types of remote patient monitoring now reimbursable: remote physiologic monitoring and remote therapeutic monitoring. RTM is relatively new. It's been reimbursed for the last couple of years. RPM is more established, but we'll talk about the similarities and the differences between the 2 types of services. Remote physiologic monitoring is reimbursement for collecting and analyzing physiological data relating to a patient's chronic or acute condition. And that information is then used in developing and managing a treatment plan relating to that illness or condition. CMS made very clear monitoring for the sake of monitoring is not medically necessary. There has to be a tie to that data you're collecting and how it would impact ongoing management of the patient and treatment decisions about the patient. CMS has been very specific with regard to the types of devices that can be utilized for this data collection. They have to meet the definition of medical device under the Federal Food, Drug, and Cosmetic Act. They not necessarily have gone through the pre-approval process. In fact, a tongue depressor technically meets the definition of medical device under the statute, but it does have to be a device that meets those requirements. It has to be capable of automatically uploading patient physiologic data, as opposed to not data that's self-recorded or data that is self-reported by the patient. So it has to go from the device. The data has to be transmitted to some centralized location where the data is then analyzed. The data device must also be capable of generating either daily recordings of the beneficiary's data or generating an alert where the beneficiary's values fall outside predetermined parameters. Ordering of remote physiologic monitoring, it has to be billed by an eligible practitioner, that'd be a physician or a non-physician practitioner that are eligible to bill for E&M services. You cannot order, an independent diagnostic testing facility cannot order RPM. And at present, rural health clinics and federally qualified health centers cannot provide remote patient monitoring services. CMS is proposing in the 2024, or has proposed for 2024, to add RPM as an RHC, FQHC reimbursable service under that general care management code. We'll see what happens again when the final rule is published. Again, the expectation here is that you have an established patient relationship, but this is different than that initiating visit requirement for CCM. Okay? What we're using here for established patient requirement generally is the definition that we are used to determine whether to bill the new patient E&M codes, i.e. They've received professional services from a practitioner or another practitioner in the same group in the same specialty within the prior 3 years. So that's the established patient requirement, again, for RPM, not the initiating visit if you haven't seen them in the last year. Instead, we have to have the established patient relationship per that definition. And again, we get to this issue of the referring practitioner billing versus the billing practitioner. Can a practitioner refer a patient to a third party to receive RPM if there's that sufficient degree of clinical integration between the parties so that it's seamless, providing sort of remote patient monitoring on a centralized basis? And if for CCM, there were efficiencies to be gained in that model, even more so with the technology involved in RPM. CMS has also included a consent requirement for RPM, but it's much more narrow in terms of what you have to tell them. It's really just an acknowledgement of the responsibility for the copay or deductible. Again, it can be verbal, it just has to be documented in the medical record. So briefly, let's walk through you shouldn't say RPM codes, the physiologic monitoring codes, beginning with 53. This is the code used for device setup and patient education. It is practice expense only code, so there are no assigned WRVUs. It is reported only once for each episode of care, even if you utilize multiple devices for the same beneficiary. The definition of episode of care, CMS refers this as the CPT guidelines, is when you initiate the monitoring until you attain the treatment goals. Sort of vague, but that's what we have. And importantly, only one provider can be reimbursed for CPT 99453 for the same patient for the same time period. CMS has also imposed a requirement that 99453 may only be billed if there is the collection or transmission of at least 16 days of data within a 30-day period. And you begin counting that 30-day period from the date on which data is first collected, not when the patient's educated, but day one of data collection. From that point, 30 days out, you're going to have 16 days of data collected to bill for 53. 99454 is the data transmission code. So this is for providing and programming the device for daily recording and alert transmissions, plus the collection of data and normalization of data for review. Again, has to be automatically transmitted, not patient reported. This is also a practice expense only code. There are no worker reviews associated with. It may only be billed once through 30-day period, again, even if multiple devices are utilized, and only one provider can bill for this code for the same patient for the same time period. And once again, we have the requirement of 16 days of data collected in 30 days as a precondition for submitting a claim under 54. 99091 was the original remote monitoring code. It is data analysis and interpretation. CMS has kept this code even after adding the new codes, noting that after you've collected the data, the next step in the process is going to be analyzing and interpreting that data, and that would be reimbursable under 99091. That code requires 30 minutes of time and a 30-day period. There is no add-on code for 99091. The service must be provided by a physician or non-physician practitioner or by clinical staff if the incident to requirements are met. However, in this case, it's direct supervision, not general supervision. Now, again, through at least the end of this year, direct supervision may be accomplished virtually, using the handy-dandy smartphone. And CMS has proposed to continue that through the end of next year. But if you are billing 99091, appreciate if clinical staff is doing this work, you have to be able to meet that direct supervision by the billing practitioner requirement, again, either virtually or in person. It's less clear from what CMS has commented on, but it seems more likely than not that the 16-day requirement also applies to this code as well. You'll have to have 16 days of data. It's just not as crystal clear in the Federal Register notices as it is for the other codes. We then get to the RPM treatment management services, which are akin to our chronic care management services. Again, two codes here, 99457 for the first 20 minutes of treatment management services, 99458 for each additional 20 minutes, up to 3 units can be billed of 99458. This is clinical staff time under the general supervision of a physician or non-physician practitioner. There is no RPM treatment management service code for services furnished personally by the physician or non-physician practitioners. There's no equivalent code under RTM for that. CMS does require that in the 20 minutes, there must be a live interactive communication with the patient, which they define as real-time synchronous two-way audio interaction that is capable of being enhanced by video or other types of transmission. The treatment management services also appear to carry the 16-day of data requirement. CMS once again made clear that only one provider will be reimbursed for 99457 for the same patient during the same time period. And you may bill 99457 and other care management codes, so principal care management, chronic care management for the same time period, but you have to be clear that the documentation supports the distinct services. Of note, if you compare well, we'll get that in just a second when we compare the reimbursement. Interestingly, if you read the CPT code book, it says that 99457, the remote RTM treatment management services, cannot be billed with 99091. CMS takes a different view and says, in fact, in some instances, when it's a complex case and time needs to be spent analyzing that data, then it would be appropriate to bill 99091 as well as the treatment management services in 99457. Of course, they are cautioning you that you don't use the same time to meet both codes. So you have to have a distinct 30 minutes for 99091 and the distinct 20 minutes for 99457. And again, they note that this is, in some instances, again, exception, not rule. So you wouldn't necessarily, for every single patient, bill every single one of these codes. On the RPM reimbursement, again, these are 2023 rates. There are small adjustments that are made to the RVUs proposed for 2024. And again, the conversion factor is still at play. But I would note to you, particularly on treatment management services, the reimbursement there, which is just at $49 for a non-facility, that is lower than the reimbursement for chronic care management. So what we are seeing is marrying RPM front end, so the data transmission, the education and supports, with supporting chronic care management with the full development of the care plan and billing those codes as opposed to billing the RTM codes. Doesn't go, you still have to meet the requirements for CCM, which are distinct for the requirements for RTM, but we are seeing programs that are emerging that direction to take advantage of the higher reimbursement with CCM. To the codes, 99453 and 54 are tied again, or services furnished in a hospital outpatient department, they're tied to an APC. For 99453, it's APC 5012. The reimbursement there is $120. Note that is 5012 is the APC for an office outpatient visit. And so if you are subject to the site of service differentials, remember 5012 is the one APC that will always reduce down to the lower rate when furnished in an off-campus setting. So regardless of whether it's a grandfathered or non-grandfathered hospital outpatient department, you're going to get that 60% reduction down to the equivalent fee schedule rate. If it's an on-campus department, it would stay at the full rate. And then there's 99454, data transmission, ties to the other APC, which reimburses at $35. Just note that the modifiers the status indicators on 54 would no pay if billed with APC 5012. So it will be bundled up into the first month when you bill the service initiation code. So let's flip from RPM to remote therapeutic monitoring and what we're trying to accomplish here. Again, both are going to require FDA medical device. Both appear to require 16 days of data to be billable. RTM, however, permits patient-reported data as opposed to the automatic transmission for RPM. RTM is actually limited to 3 conditions. You can only utilize that if you're monitoring respiratory, musculoskeletal, or cognitive behavioral therapy. And cognitive behavioral therapy was new last year, sort of still figuring that one out. Unclear at this point, based on statements made by CMS in the proposed 24 rule, whether the established patient requirement applies to RTM or not. RTM codes, interesting, are not E&M codes. They are in the 9.7 series, I believe, meaning that they can be billed by any professional who can bill under the Medicare physician fee schedule. However, that means there's no incident to billing for these services. They must be personally performed by the billing professional. Note that CMS proposes in the 2024 proposed rule to permit physical therapists and occupational therapists to bill for RTM services that are actually furnished by physical therapy assistants or occupational therapy assistants under general supervision. So we'll see where that clarification goes. CMS has also noted that a provider cannot bill for RPM and RTM codes for the same patient for the same time period as well. You get, of course, one bite at the apple. Here you see the 9.8 series, I apologize. Here you see the reimbursement for RTM services, nearly the exact same as they are for RPM services. Same APC crosswalks for the service initiation and data transmission. Note that the differentiator here is the data transmission code because that is the one that is tied to the specific condition. So one is for respiratory system, one's for respiratory system, one is for the musculoskeletal system, and then one for cognitive behavioral therapy. As I noted, that's very new. CMS did not actually price out that code. It is left as contractor priced for this year. We've not yet seen what the number proposed for 2024 would be for that particular service. So you see the reimbursement differences there. Again, for more information on remote patient monitoring, we annually update and sometimes semi-annually update our guide for remote patient monitoring that's available to you for more services. So that was our overview of some of our favorite codes, the chronic care management and the remote patient monitoring codes. I do it myself sometimes, sorry. Of course, if you have questions, include them in the chat or after we finish up the webinar, take the survey for that information as well. Next up for Healthcare Regulatory Roundup, we hope, on October 25th, Kathy Reep and I will address some new proposed rules for the No Surprises Act. One has been published, the changes for the rules around the administrative fees. The other proposed rules still sitting with OMB that would change the independent dispute resolution process. So we're anxiously awaiting to see what those new rules look like. There's also been new guidance that have been published by the agencies with regard to the No Surprises Act, so we'll take a deep dive there. Otherwise, we hit November and December and it's final rules time, so stay with us. We'll do our best to walk you through all the changes. So back over to you, Laura.
Thank you. And thanks to our presenter, Martie Ross. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you will receive an email with her contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and to post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.